Welcome to the Frank and Lizzie Show. My name is Frank Avalos. I'm a co-host, and with me I have the beautiful and talented Lizzie, aka Elizabeth Faust.
Hi, how are you?
And so today we're going to be diving deep into brand new technology, into the world of innovative biopsy coverage as well as debridement. And we have two incredible guests with us today. I'll introduce the first one. Today we have Dr. Neal Lonky with us. He is the CEO and founder of Histologics. In addition to that, he's the clinical professor of obstetrics and gynecology at the University of California, and he's a developer of Kylon, which this is cutting edge technology, no pun intended.
And then we also have Dr. Traci Kimball, MD, MBA, CWSP. It goes on and on. She is the CEO, Chief Medical Officer of Wish Clinic. She's a brick and mortar in the Denver suburbs. She's also the founder, CEO of Wish Innovations, which is a public benefit corporation that has hemp-derived solutions. Adjunct faculty of Emory University's WOCN training program and DeBusk College of Osteopathic Medicine. So amazing guests with us today. Thank you guys for taking the time.
Yes, thank you.
Thanks for having us.
Thank you.
And so let's get started. We're excited about this because this is medical technology that's useful in wound care clinic. So Dr. Lonky, let's start with you. Let's talk about what this technology is. Kylon technology. Can you explain it to us a little more?
Yes, absolutely. Kylon is a fabric that is specially woven to present sickle-shaped hooks into tissue so that when the sickles flatten, the tips of the sickles become curettes and can penetrate the tissue and excavate tissue. And because it's developed in a row or array, there's spaces in between all these sickles, and they can trap the tissue automatically while it's removing. So that was originally developed to take mucosal biopsies, such as the cervix. And there's a lot of experience, we'll talk about it with that, but it's able to remove tissue from the body, and we'll get into all the clinical scenarios where it can be really helpful. And that was developed just over 10 years ago, with almost millions of uses now.
And so your experience as an OBGYN really helped you develop this technology primarily for colposcopies. So obviously we're wound care clinicians talking about it.
Right.
How did you make the leap from OBGYN world to wound care world?
Well, the main driver for the colposcopy was I'm an expert in that field. I have a public health degree about prevention for cervical cancer. And, we talk a lot about screening, but we don't talk a lot about diagnostics. So the diagnostics requires a really thorough view of the cervix with the scope and then biopsies. And we have some of that going on in wounds now too, with looking at the wound and sampling it. So I created a compassionate way to do it. We trademarked it compassionate colposcopy, where patients barely felt it. And I had worked with a distributor friend who also worked in the wound care field, John. And he took me to SAWC Vegas about 5 years ago, just as a guest, and I saw the gap. So I saw there are sharps, there are gentle mechanical wiping devices, but there's nothing in between. And I thought, I have a technology that can do all three. It can do hygienic cleaning, it can do mechanical removal, or it can do sharp-like debridement. It's actually frictional, but it has the experience of that. And then I saw the compassion and the speed of it, and I thought I had a product.
Yeah,
And
as a female
we deployed it.
Yeah, as a female, I've obviously experienced some of these things, and I think as much as you can to make it comfortable is great. And I'm sure our wound care patients would also benefit from that. But I know the first time I talked to you in Boost, we were talking about the versatility of this product.
Right.
And we go to Vegas a lot. Tommy's sister lives there, and she's got this turf yard. And, they clean it in two ways. They do kind of a superficial clean, and then they do a deeper clean. And so they use like a broom to sweep it. That's kind of your more superficial. You're getting the leaves and palm tree droppings off of it. And then they have this like more bristle brush that is like round and you kind of like dig in and it lifts up the stuff from the base. And I was
Right.
like, that was
Right.
my aha moment. I was like, oh, that's Kylon. Like
That's
that's
exactly how
what
I
you can
teach
do.
it. That's
Yeah.
so great, Lizzie, because I say, yeah, and a punch biopsy is a little shovel, or if you're a golfer, taking a divot from the
Mhm.
turf.
Listen, I use
Yeah.
this all the time in practice and people are scared of it.
Yeah.
Yeah,
And,
yeah.
So that's why we say don't fear the finger.
well, now that you brought up the finger, let's talk about this because Lizzie, we got this product as you showed up at our office. And when I looked at it, how simple is this going to work? And so I want Dr. Kimball, let's talk about the clinical side of it. Tell us more about your findings.
Well, Dr. Lonky alluded to how he transitioned into wound care. And what I would like to do is complete the thought and say, I actually identified a solution that I needed for my patients that were going to basically supplant or substitute the fear of cold steel, that was going to have safety and in terms of bleeding risk and taking too much tissue, and also efficacy, getting the most appropriate or accurate amount of tissue for us to do what we needed to do, which was to determine one, is there an infection or chronic, biofilm that is providing barriers of healing? Number two, is there a gross and microscopic level of necrosis that needs to be removed to incite a healing response? Because as we are learning is that we want to convert a chronic senescent wound into one that's more acute. And three, one that was going to incite enough bleeding to actually be nurturative for that wound bed and create an in situ clot, autologous clot in the wound for us to actually deploy and do wound bed preparation for things like CTPs or biologics or wound fillers like collagen and amorphous substrates. So I was looking for this kind of tool because I wanted a new wand in my toolbox. As the wound wizard, didn't mention that, but it was really part of our branding to find a wand that was going to do all these things and be versatile. And that's when I was introduced to Kylon. And Neal and I have been colleagues now for 4 years, and here we are.
It's great, Traci.
Traci.
So would you like to know more about the clinical nature of what I do and how I use it?
Yes, because here's my question. One thing that I was impressed is let's talk about if you go to your website, you talk about patient friendly, effective, and efficient. And so I want you to kind of describe that. But the main thing is that patient friendly and the pain factor is what I would like for you to elaborate.
Okay, so let's understand one important fact about chronic senescent wounds. If you feel it, you can heal it. Because the neuropathy and pains we know this, if nerves aren't coordinating the healing process, wounds are not going to heal. That's why we have diabetic foot ulcer. Neuropathy is such a big part of this. And so why we like the idea of not having a wound that's painful, we have to get over the fact that those who will heal will feel this, feel wound care, feel our hands doing something to them. But the thing that I've gotten feedback from is that when I approach them with a Kylon fabric pad on my finger, it's not sharp, cold steel, they actually are more comfortable, one, with that approach. Number two, when we actually begin to do things like turf hygiene, as Lizzie calls it, or this rototilling or this mechanism that gets a deeper clean where we're twerking and twisting and removing more deeper necrosis or invested necrosis with biofilm. We're actually doing this with a more compassionate approach, and these patients are saying that they're more comfortable. And now they're asking, are you going to use that again? Because look at what it did. Because they come back and now we have evidence that we're stimulating granulation tissue. We've caused micropunctate bleeding. We're creating a blood clot, and we're doing all these things and pulling all these levers and getting that wound from a chronic senescent state into a more acute healing state. So that proves in itself, one, that it's efficacious, that we are keeping patients excited and trusting the process. and efficacious in the sense that we're stimulating and creating granulation tissue and providing wound bed preparation.
So, in my experience, I think some of the hardest areas for me, particularly with like a scalpel, is to really address like the wound edge unless it's really well demarcated. Because I think for patients, that's the most painful area. You know, they might already have a lot of necrosis in the deeper areas of their wound. So do you take this like all the way to the edge as well and able to, because we know like the edge is like, you know, part of our dime time principles, right?
That's right. Yeah, and Neal, if you want to jump in here and talk about why you created some different types of tools to do and
Sure.
address the edge first,
Sure.
and then, I mean, I'm just going to say yes, nod.
Sure.
We have, this is a versatile product. Kylon is the technology, but the actual wand or the tool is created specifically for certain elements of the wound, you know, either hygiene or debridement.
So this is the version for debridement, and the purple one is less, let's say, fortified. It can do a rapid biopsy very quickly and well, but this one is for a longer. So what happens with the Kylon, I had when I started and I came back from SAWC, I did some cases with a plastic surgeon in my California neighborhood, and he said, "Oh, that's just like Mohs surgery for wounds." And I said, "Wow, can I quote you?" And yes. So think of it like this, Lizzie. Yes, it is the most sensitive area, but when you go millimeter by millimeter and you're getting to the area where the nerves just start to emerge and feel the sensitivity. So you can incrementally, and as Traci alluded, when you rotate it, you're shaving or excavating, but when you're wiping, you're raking. But when you're just paintbrushing, like a paintbrush, it's hygiene. So Traci's going to go through that a little bit on the clinical side. But yes, on the wound edge, because you can modulate the pressure and the function of the Kylon, you can get a very precise marginal debridement. And because it's a margin, usually this is the tool. You can do it with the finger cut as well. One more thing, the finger cut was really designed because people said those things are pretty small, like a small dermal curette. Do you have anything bigger? And then I realized time is money for everyone in medicine. Access is key. So the faster you can get through a debridement, by the way, the less pain people have. Because pain is not just about how deep you go and how much it hurts, it's how fast you can get it done. So that was the driver. What do you think, Traci?
Yeah, and I think nociception is relying on how efficacious it is to cut tissue versus to bluntly push and pull. And so understand that this is an FDA cleared device as a curette in the literature. And so these Kylon hooks are efficacious in the sense that they're actually cutting and with force. But the fact of the matter is not every scope can actually debride. And so Neal's product actually spans the continuum of scopes. And so the paintbrush is more of a wound hygiene. So in that appropriately scoped practice or professional, they can use the tool and do wound hygiene. And they can do it as often as they need to. All the way to the scopes that can be more invasive and do full-on debridement and actually get paid to do that. So that's one thing about this is that in my office, in my hands, because I'm fully scoped to do debridement, I use it in a debridement deployment. I use it for biopsy for the most part. So that gets into more of the reimbursement conversation, and we'll leave that for later. But that's what my point is that it's clinically versatile. It can span all scopes of practice, and depending on the torque and the force, you get a different outcome. And also remember that it's very low risk because yes, it causes bleeding. There can cause bleeding, but we're not removing significant, or there's no danger to remove a significant amount of healing tissue underneath this fibrin that's, semi-adherent or slough or even necrosis that's already starting to granulate underneath because of the depths of the hooks.
Yeah,
And
I was gonna just say with Lizzie's example of the turf, I could take a knife and shave the turf off with a curette, right? Or I could use friction, which is how this works. And then clumps of sod come up and they get trapped. That's the way we teach it. So exactly the way Traci was explaining it clinically.
Uh, I do want to add, Dr. Lonky, Dr. Kimball, thank you so much. What I see out in the field is that, I'm a physical therapist. I can do sharp debridement, but I have to work with a team that can debride. And sometimes I feel like with sharp debridement, we need a skill, a certificate. We need a lot of training. Tell me about the ease of use of your product.
I'll let Traci start with that one.
Right. Well, Neal alluded to it. So this paintbrushing approach is, just this light wisp, and depending on the adherence of the tissue, the target tissue you want to remove, because remember, it's all about what we take out of the wound, not what we put into the wound, right? Our bodies are programmed to heal itself. So removing barriers of healing, well, things that are in the way for proliferating macrophages and, fibroblasts and epithelial cells, we want to take that off. And so that's wound hygiene. That paintbrushing approach can be done by appropriately scoped, trained individuals that don't need sharp debridement certification. Now, of course, are we incentivized to do wound hygiene? No. Should we do wound hygiene? Yes. And so that's a political conversation we'll leave out of this talk. But pretty much the paintbrushing approach can be done clinically, even by the patient, to be honest. But this isn't a direct-to-consumer model. This is a B2B2C. So, but anyway, a skilled professional who does wound care that doesn't need a certification or doesn't have a certification for sharp debridement could still use this tool and be effective for wound hygiene.
We have a teaching tool on our website with a banana. I can take credit for being the first banana guy. I also have a Bartlett pear demo for cervical cancer because a Bartlett pear looks like a uterus and a cervix. So, we have a regular fruit salad at Histologics LLC. So we're using the banana and we're showing slough being painted off, and then we rake and we see a divot, and then we do the mechanical twisting, which is the torque that you talked about, that deploys the curettes. This is 30 curettes on a finger that are micro curettes. And Traci innovated a way to stimulate the wound bed, even if you use any other kind of debridement technology, like any kind of other debridement, but you're not getting that micropunctate bleeding. You want to tell them a little bit about that part with the perforation?
Yeah, so
did a published abstract at Saucy.
Yeah, I presented an abstract many years ago of actually stimulating granulation tissue formation over Achilles tendon in a patient with a pressure injury. And I needed a device. I was looking for a tool that was commercialized and cleared by the FDA to do this, and I found Kylon. And basically, if you are putting downward pressure just straight down perpendicular to the wound base, you're actually deploying these hooks, which are sickles, right? So you're deploying them into a full-on microneedle, and you're creating micropunctate bleeding because you're microneedling the surface, like aeration.
Oh, I love microneedling.
Yeah. So my tool at that moment, was initially just a hypodermic needle, sterile hypodermic needle that was creating micropunctate or microchannels inside the tendon, right? That's avascular. And so I call it spelunking. So I spelunk and I cause micropunctate bleeding. I let the clot form in the wound bed. So that's our autologous in situ blood clot formation. Maybe I'm infringing on patents. I have no idea. But anyway, clinical judgment is what I say. But I don't have to phlebotomize the patient because I'm doing it right in their wound bed. And Kylon really helps with that. You're getting 30 microneedles going in a stamped kind of format, and you're basically stamping in a mattress sort of way across any kind of tissue, whether it's tendon, avascular, vascular granulation tissue, to create that micropunctate bleeding. And then that's bringing in all the nutrients that you want and need to interact with some of the other tools in our toolbox that we put in the wound, like biologics.
I'm going to change my name to Neal Spelunky now. I love that. So the nice thing about this is it's 20 micro needles on a stick, because once they flatten, they're needles. But the good thing is they're only about 1.5 millimeters deep. So that as much pressure as you put in, so you're not going to like spear the wound or cause too much excess bleeding with it.
Well, the way I see it is that I've had these in my toolbox, and now I can go with like this, right? And then potentially a finger cut. But I mean, as Traci, I got my MBA this summer as well. I know you recently got your MBA, and I think it all comes down to, part of it comes down to a lot of clinicians about the reimbursement.
Mm-hmm. Yeah, the economics have to make sense, right? Otherwise, you don't have a business model. That's what we're told in school. And nobody's writing checks to invest in you. So you got to have a commercializable, efficacious, safe product for the FDA. We've passed that. You got to be able to actually make money if you want to keep the lights on. And we have that too. So in my clinic, we've actually validated and tested the reimbursement structure and economic model of this. For wound hygiene, they're really, the cost margin for these products don't make it cost prohibitive at all to do wound hygiene at all. And sometimes it's easier, to grab a gauze in certain venues. If you don't have Kylon, that's what people are using, right? If you clean it like you mean it.
If they do anything.
Right, if they do anything. They need an order. And if it doesn't have an incentivized revenue factor, then they're not going to, they're going to ask you, are you sure you want to do that?
Yeah.
And my answer is always yes, and here's why. Because ultimately, over the lifetime of that episode of care, we want to be efficient, effective, and cost efficient too, and fast. And that's what Kylon pretty much can do. So you do wound hygiene a few times, you clean that wound, get it into a therapeutic, you basically, it's a theragnostic. It's not just a diagnostic, it's a theragnostic. And we'll go into some of the, we'll talk about this therapy point of it. But you're stimulating granulation, you're doing wound bed prep simply just because you're removing superficial slough and fibrin. And that's done with, that's our classic wound hygiene. What do you bill for? It really depends on what you're taking off of the wound, and you have to look at the level and the viability of the tissue that you're removing. So if you're just removing exudates, you're not removing any epithelial margins or anything like that, then there really isn't a revenue code. You could say 97602, which that doesn't bundle in any other site of service other than the place of service 22. And so, whether or not we get lucky and someone pays you for that, if you send it in a site of service 31, 32, or 11, or 12, or 15, is still meant, still left to be determined. But we get even deeper and we're doing a selective excisional debridement. And that's skin level only, removing exudates, removing skin. You're not removing specific like subcutaneous muscle fat or anything like that. Then that's a 97497. And
well, there's so much we could talk about with the reimbursement. I'll leave it to Q&A, and maybe they can visit in the Histologics booth, because certainly every site has its own issues, right?
Mm-hmm.
So we would like to thank you both for coming on the Frank and Lizzie show. And we want to make sure that the viewers know that you can visit the Histologics booth in the Product Education Center. I know there's going to be videos on there so they can see it in action. And we'll also have a little bit of time for Q&A as well.
Right. And Lizzie, and I do want to say something. I've used the products, but I work at 2 clinics that we love that finger caught. Patients love it. The pain, they don't feel it. And as well as we do it before we apply the cellular products. Phenomenal.
Hey, Lizzie, may I suggest one more use of it?
Okay.
We have this version because people said, I learned about wound tunneling and crevices and interdigitary space, and this is the CWSP. This is actually the most compassionate way to take an endocervical canal biopsy, but it's called CWSP in the wounds, and it can go into crevices as long as you can see it. I wouldn't recommend you go deep into tunnels with it where you can't see it, but there's always been that thing where, what about if it's in a fold or in a, so this, I just wanted to mention it.
Okay. And they can see that in the booth as well.
Yeah.
Great.
Yeah.
All right. Thank you guys so much. Appreciate all your time today. And we look forward to getting some questions.
Thank you.
Great. Thank you.
Have a great conference, everyone. Thank you.
Thank you both.